Bill, any comments on some of the newer agents that are coming online in the metastatic setting and how these might get integrated in early stage disease?
Well, you know, it's a crowded space, which is a good thing. We wish we had similar problems in other subsets of breast cancer, but certainly with respect to, you know, more recently the introduction of pertuzumab, TDM1 closely behind, and, you know, a variety of other small molecules, you know, the challenge is going to be how to optimally use these and sequence these drugs. It certainly seems that using the antibodies are better tolerated as a therapy, as opposed to small molecule either alone or with an antibody by more toxicity. But clearly it's resulted in the preoperative setting, as Joyce was talking about, higher pathologic response rates, and even in a fraction of patients in the absence of chemotherapy, which we just have to get a little bit smarter in figuring out who can avoid the chemotherapy so we can really leverage the effect of these agents. But I think it's actually a very exciting time, and I think it's actually going to be a big challenge on how you develop these drugs, because the number of patients that will be required, you know, with so many agents out there that clinicians can use, it's going to be a tough road to get newer drugs approved.
Yeah, and we've been a victim of our own success, because the number of events in terms of recurrences is much lower now, and many of the trials, in fact even some of the duration trials, were having trouble having the statistical power because the event rate was lower than expected.
Yeah, and it's funny because I was just thinking about how pertuzumab was approved in June. We're happy we all get the email, it's approved. And we did work, we participated in the Mariana trial, but I've actually not had the opportunity to use pertuzumab because I haven't had anybody that's relapsed who has HER2 positive disease. And I think that's really a very powerful statement. I mean, I think it's great.
And the other area that we should cover, you know, we haven't talked about hormonal therapy a lot, but clearly hormonal therapy is the drug that has the biggest impact in hormone-sensitive disease. Christy, any comments that you have on new directions in the adjuvant setting, looking at hormonal therapy regimens, perhaps trying to improve upon where we are?
Well, there is the SWOG trial that has been initiated at this point, and we'll talk further about the use of the mTOR inhibitor everolimus in the metastatic setting. But with the success of that trial and the really significant benefit in the metastatic setting, that's now being rolled into the adjuvant setting. So women will, when they're receiving their hormone therapy, will be randomized to receive the everolimus for the first year of their hormone therapy to see if we can improve on their outcome as well. The other thing we didn't really touch on is the issue of patients who are HER2 negative by FISH, but they're 1 or 2 plus by IHC, and there is the ongoing NSABP trial looking at the use of trastuzumab versus not with their chemotherapy in that circumstance as well. So a little smattering of very large trials in more unique populations than are just clearly HER2 positive patients.
And the final issue I wanted to touch on briefly is we know that hormonally sensitive disease has a very long natural history. Patients can have very late recurrences. So there's an interest in prolonged use of treatment, particularly with aromatase inhibitors. And I was wondering if anybody on the panel is using more than 5 years in select patients, and when we might actually have some real clinical trial data information on that.
I certainly do it not as a routine, but you know, I think we can all think of the patients that have many nodes. At the same time, they seem to be tolerating the drug okay, and their bone density, you know, if you get those things converging at the same time, that may be the type of patient where with a discussion, even in the absence of clear direction from data, that I would continue it. But we're still waiting for some of these extension trials, including the one from the MA17, that will hopefully tell us whether, you know, really long durations of therapy. We're starting to talk about 15 years of therapy with some of these trials. And I think the other piece we have to recognize in all of this is that there's a compliance issue that's, you know, another big thing in the room, that it's hard enough over 5 years. We don't know what's going on at 10 and beyond.
Yeah, you know, if you look at the update of the TEAM trial that was published and also a recent update of ATAC, and if you look at hazard rates by year, because if you just look at the curves, the Kaplan-Meiers, you don't see this, but if you look at recurrence rates per year, through year 5, patients get treated, and then there's about a 3-year gap, and then both the tamoxifen and AI arms, the annual hazard rates start to slowly take off. Interesting, both of those. Those are the longer 2 data sets that I'm aware of. I haven't seen that for Big 198, but I actually carry that in my pocket, in my white coat pocket, and show women that, because I think we're getting close. I think we're probably a year, 2, 3 away from the longer versus shorter duration trials and the follow-up on the MA17 of 15 versus 10, et cetera. So I tell women, you know, if we've guessed wrong and you didn't need an extra year or 2, we probably haven't lost that much, you know, but I'd rather err on that side. So for the higher risk patients, I'm saying, how you feeling? You know, you feeling okay on it? And if you're feeling okay, why don't you just keep taking it for another year or 2 till we have some answers?
I'd say a lot of my patients come in with very strong opinions right at the end of their therapy.
Yeah.
I demand more,
Exactly.
or thank God I'm coming off this drug. So, to me, it becomes a little bit of an easier conversation based on their very strong opinion at the end of their therapy.
No, I mean, some patients even say, look, the natural history of this disease can be modified. I mean, they're smart enough. They know that the MA17 took patients after 5 years of tamoxifen and showed an ongoing risk reduction. These patients are still at risk. So I think this is one of those areas where we're practicing beyond the data, but I think in some cases the right way, but we have to wait and see what the data shows.